Hello, ladies and gentlemen. We're honored today to have with us Dr. Johnny Delashaw, who is the new chairman at University of California at Irvine. Our discussion will be in two parts. The first part will be discussion regarding microsurgical management of supratentorial arteriovenous fistulas. The second part, which will be a separate session, will review the details regarding management of infratentorial arteriovenous fistulas, and more specifically, superior petrosal sinus AV fistulas. Johnny, thank you for joining us. I'm going to go ahead and briefly review a case just to get our excited about our presentation today and show the associated surgical video. First, let's go ahead and review the disclosures of the presenters that you can see. This is a 52-year-old male with a sudden onset of headache who presented to the ER a few days later. So the presentation of this individual was rather in a delayed fashion, and that could potentially affect the distribution blood along the head CT. As you can see, there is some blood along the sylvian fissure. However, a cerebral angiogram revealed this abnormal connection along the olfactory tract potentially and the ethmoid area from an artery directly to a cortical vein. So this would be consistent with an ethmoidal arteriovenous fistula. Let's go ahead and review the 3D angiogram for this patient, which could potentially better illustrate the details of the anatomy. As you can see in this 3D presentation, this is the carotid artery and MC and AC, and you can see along the crista galli, there is this abnormal connection, the artery to vein, the cortical vein right there. And this 3D anatomy really, as you can see further looking forward above the eyes here, the location of the fistula. As you know, the finding of this patient would lead us to believe treatment is indicated due to the fact that the fistula does have cortical venous drainage and could potentially place the patient at the future risk of cerebral hemorrhage or further cerebral hemorrhages. Let's go ahead and review the surgical video in this case. So we did this case through an eyebrow incision or a supraciliary incision, Johnny, and placed the patient in the opinion, turned the head about 30 degrees contralaterally, rather than going through the incision behind the hairline because his hairline was very far back anyways. We use a supraciliary incision, as you can see here, and not necessarily in the eyebrow because of the risk of alopecia due to coagulating the skin edges. Do you like this approach for these lesions?
I think this is a very reasonable approach, particularly for the gentleman's hairline. It's not one I typically use, but for the hairline, I think it's very reasonable.
I appreciate it. So you would have considered this in this situation because of his hairline?
Yes.
As you can see, we go ahead and use a microscope because we want to preserve the nerves, the supraorbital nerve, as you can see here, which really limits us medially in our incision, and use a Colorado needle on the bovi, not to bovi materials or the orbicularis oris muscle. And then laterally, we're going to be really going as much as necessary, a little bit beyond the eyebrow. And under the microscope, you can appreciate the branches of the frontalis nerve and the soft tissue that is over the temporalis muscle. So at this juncture, we want to definitely pay attention to the frontalis nerve, and we're going to focus on it in a second to better define the nerve. Here is focusing down, and as you can see in a second, those are the branches of the frontalis nerve that obviously have to be preserved to prevent any cosmetic deformity because of frontalis palsy. Any other details you would consider important here, Johnny?